They say it's very quick. It could be better. It's not where I want it to be. Those are the descriptors I usually get. Once in a while, I get a parent who may say, he has this intense gaze. And I quote the word intense gaze because that's what they say to me. There may be little or no index pointing. And, when we speak in the Caribbean or just about anywhere, we use our hands, we use our facial expressions. So as I get excited, you see my eyes widen, my hands go up, the pupils really dilate, but you get a whole heap of movement that describes. And for somebody who's not able to hear, they would know that either I'm getting excited, if I'm getting angry. And I usually say to parents, think about a mute and deaf person who's signing, and you know exactly what's going on, even though you don't know what the content is because of the mannerisms or the gestures that are going on. And you may say then you can have no language. Does that mean you have autism? The answer is no. It says limited use of gestures to communicate, which means that even if I'm mute and deaf, but I want something, I'll come and tap you. I'll look you in the eye and then point and look to what I want you to get for me. And I double back and check joint attention to make sure you're looking at what I want. But parents don't see that. What they end up having is a kid who comes to them, pushes them to where they want, or pulls them by the hand, or uses their hand to extend to get what they really want. Some kids simply walk into the fridge and start crying, and the parents need to figure out what it is that they want. And I usually say, this is what we call the guessing game. But it really is a typical non-verbal social communication. Second subdomain for social communication impairment. Next, you realize that the kids are not really interested in their peers, or if they are, it's a specific individual. They go and sit beside little Johnny every single day. They follow little Johnny around only. There's no engagement with anybody else. Or parents will say, her teacher is her best friend. She sits in her teacher's lap all day at school. That's not the reason why you sent the kid to school. You sent them to help socialize. So when you're not interested in your peers or it's very limited, we have concerns. And again, the kids may not interact or participate in games as how you would expect them to be. When they're approached by others, simple little things like somebody saying hello, it's not that we're saying that all kids will be bright and chirpy and walk up and say hello as well. But some kids will hide behind mom or dad or behind their teacher and it'll just say a little shy wave. Those are acceptable. But for the kid who turns away, who's not interested, that's when we start to become concerned. Another concern you may have with them is that you may not always see them. You see them playing, but the play, if you looked at it really carefully, you realize it's the same thing over and over and over again. They drive the car up the top of the chair, let it drop at the back, pick it up, come back again, and it just goes over and over. There's nothing more about the play. They're never driving over the river, over the cushions, which have now become the mountains. There's none of that. It just goes up, down, up, down. Or you have them dismantling the toys and parents say, they're interested in how it works. But we don't all dismantle our toys and pop off the wheels and hold on to the wheels or anything like that. Or the parents may say, completely dark, I have a bag of toys, yet the child picks up a string from the map and everything else he just puts aside. There's nothing else. And he twirls the string all over and over for the day. Again, we're now having what we would refer to as deficits in maintaining relationships. Remember, you need to have features from all three to consider social communication impairment. But the other domain says you must have a pattern of restricted or repetitive type behaviors. So examples of those may be a kid who has echolalia. What is your name? What is your name? And says it exactly the way it is said. You often hear it in terms of them watching television. If you listen to the way how they pronunciate or enunciate the words orange, for example, orange, and it's saying just like how the cartoon characters, parents will say that they have a cartoon accent. Really, is the echolalia that has come about. You have some who will script shows. They will say passages of shows or the lines of the TV shows and knows exactly what it is. Undirected language. Kids are talking. Parents are on one side of the room. Kid is on the other, and the kid is talking. So parents won't say to you that the kid doesn't talk. Parents say the kids talk. However, who are they talking to? Language is usually directed because language is communicative. When we're not having that, we're having concerns. Then you get the motor stereotypies, and this is what everybody knows. The flapping, the tiptoeing, the rocking, the spinning, the finger flicking, the body tensing. Those are what parents tend to see as well. And they're often said, but somebody else also toe walk. We said that's good for them, but let's focus on what's happening here in this kid, and is there any other issue? And then object plate use, we see the lining up, we see the organizing, the spinning, the dropping that you can get. But these are all examples of stereotyped repetitive, either speech, motor stereotypies, or a repetitive use of objects. Then you have kids who want you to do things in an exact same manner. And it could be that you walk down the stairs and every morning you say, hello, sunshine. And every morning they want you to say it the same way. Or the morning you're not there to say it, then there's a meltdown. So that's when kids want things to be done in a specific way. Drive in a specific direction. And if you turn the wrong direction because you decided you want to do an extra errand, it then causes frustration. They might be distressed when items are placed in a different position in the home. So the ball is usually on the left side of the room and you decide you're going to rearrange and you put the ball on the right side. Or I've had a parent who decided at Christmas one year she was going to repaint the house in a different color. So to her, could you not have at least left his room the same color? It causes distress. They may have a specific play sequence. And as I said, it's really looking at insistence in sameness. Excessive adherence to non-functional routines. When we look at atypical sensory behavior, whether it's hyper sensitivity or interest, we're looking at sensory aversions. For example, doesn't like soft foods, only like crunchy foods. They don't like sand on their hands. They don't like walking on certain surfaces, or some may be sensory seeking. So they come smell you. They may come and rub you. They may like the feeling of stockings or like plush toys and just constantly rub. Noise is a good one. And the blender, the lawnmower, the weed whacker, what I call the yang bikes, or the motorcycles, all cause distress. And then the side eye, where they will look at objects or look at you, not directly, but through the corners of their eyes. And this is reflective of your atypical sensory behavior. The fourth one in this domain is really restricted or fixated interest. Fascinations with fans. Walk into a room and cannot pass the fan. Or being insistent, the AC is running, but there's a fan in the room and you're still climbing up and above. And you'll find all sorts of ways to climb over a chair, to get on a bed, to find the switch for the fan because you want to see the fan switch. There might be intense interest in cars. And I always joke and say, I know cars by colors. They're blue, white, red. But no, you have a kid who's going to tell you make, model. You get license plates, numbers that they may memorize. And then you can also get kids who may have unusual attachments. Have a kid who walks around with 2 crackers in his hand and they must look the same. But he always has to have the 2 crackers, so the unusual attachments. Or the kid who must have something specific in their hand. So it could be like cars, bottle stoppers would be another good example. These are all examples of your restricted or fixated interests. And it really brings to life what social communication impairment can look like, as well as restricted and repetitive patterns of behavior. Remember, you need deficits in all for the social communication and just 2 of the 4 for restrictive and repetitive patterns of behaviors. So some persons will say to me, but that don't happen anymore. Again, he don't walk on his tippy toe anymore. Just remember, it can be a history of, it could be presently now that the kids have it, that we are concerned about. And then remember also that we talk about having the presence of symptoms, maybe not all of them to meet criteria at the very beginning in the early developmental period, but it must cause impairment in function, and it cannot be better explained by either intellectual disability or global developmental delay. So I mentioned 18 to 24 months as a time when all of these symptoms are starting to emerge. There's a 9-month visit. Nothing much might be seen when you see your healthcare provider. There's a 12-month visit, and again, may not see anything, but definitely when you're coming to that 18-month visit, signs have definitely started to emerge. Now, in pediatrics, we do something called developmental surveillance. We really want to find out what parents are concerned about. We really want to see if their concerns are in keeping with what we would have expected or not expected. We want to look back at that developmental history and compare. We want to look to see, are there any factors in that kid's life that should make me concerned even a little bit more about this kid? So prematurity, hypoxia, that sort of thing. And that's what we refer to as developmental surveillance. So it is the perfect time for the parents to voice their concern. But at developmental surveillance is done, yes, at 18 months, but it's done at all well visits. But because I said 9 to 12 months, you may not have any signs yet, or the parents may not observe the signs as yet, then we're going to leave it alone. But definitely at that 18-month visits, you're going to have signs. At the 18-month visit, there's also the need for developmental screening. So in the surveillance, I ask you questions and I kind of tick, you're doing it or you're not doing it. But in that developmental screening process, I'm now use a standardized tool and I'm asking you very specific questions pertaining to your development. And I notice there are different countries online, so I will say, each country tends to have their own developmental checklists. Not that they're different values, but their developmental process for reviewing their milestones. It might be inside in the passport, for example, within Jamaica, there's a developmental passport that has immunizations and also development. There are some questionnaires in there for developmental surveillance. So you can do it in that process as well, but there are other ways to do it. However, when kids come to that 18-month visits, the stories I've heard, especially for parents who have voiced their concerns, is often that they are reassured for some reason or the issue is dismissed. And the reasons usually are, oh, he's a boy, so he's going to not talk as early as the girl. Just remember, we have one set of milestones. The girls and the boys, we don't separate. So if the girl is talking, the boy should be talking. We go on again. Oh, daddy or uncle spoke late and look at him now. He's a doctor. We said those persons have proven themselves. A late bloomer is a diagnosis of exclusion, which means you've ruled out everything else. Do not accept those two as a reason as to why your kid is not yet talking. Or the other one, all children develop in their own time. And partly it's true, all children develop in their own time. But for everything, there is a comparison to see whether their own time matches up with what is average or what is expected. So parents must be empowered to ask the questions to ensure that their concerns are met. And if they can't find a solution at the first stop, trying to find a solution at a second stop. So we spoke about the MChat, which is really the modified checklist for autism in toddlers. There are parental tools, which are online, which you can download and you can ask the questions and everything. But even if you did those at home by yourself, I will encourage you to do it with your physician if possible, to ensure that you are not overly worried, but also not to discredit whatever you've done. But do it with someone who has had more practice in doing the screening. And as I said, the MChat is a screening tool. It is a specific screening tool for autism. It doesn't mean you won't pick up anything else, right? Because it only has a certain amount of sensitivity and specificity, but it has clear cutoffs. This is when you need to be concerned. This is when you don't need to be concerned. And it's a standardized tool, which is replicated and which has been tried and tested. It really has two parts of it. So it's referred to as a two-stage parent report screening tool, which assesses the risk of an autism spectrum disorder. It has 20 questions with follow-up questions for each question that you answer incorrectly or where the answer reflects a risk for ASD. Screening positive now does not always mean ASD. You may also mean a high risk for other developmental disorders or delays, and it really says that evaluation is warranted for any child who screens positive. The beauty of the MChat, as I said, you can go on some parent sites and you can download versions of it. Physicians can download a free version as well and can utilize it in their offices. So what does the MChat do? I said it screens for the risk for autism, and it really stratifies risk. Depending on your scores for 20 questions, if you answered less than 2 or less questions which signify risk for autism, then you're considered low risk. If you've done this tool before your second birthday, they say to you, repeat it at your second or after your second birthday. If you score between 3 and 7, then you're medium risk, and it says to you, administer follow-up questions. The follow-up questions really delve a little bit more into the scenario. And for example, when it asks if you point for objects, it may ask, how do you point? How do you get there? How do you indicate? It really asks more about the scenario for pointing to ensure that when you say no, it is really a no, and that helps to increase its specificity. If you've screened negative, it means that you've gotten a score somewhere between 0 and 1. If you've screened 2 or above, they say refer for diagnostic services and refer for services, interventional services. If you're high risk, I said forget all about the follow-up questions, just refer directly, because it means that you've scored above 7 on questions which are suggestive of risk for autism. The MChat, I hope it projects well, looks like this. 20 questions, you either answer yes or no. And I was pointing out question number 7. Does your child point with one finger to show you something of interest, or 6 finger to ask you for something to get help? 2 different reasons why you point. 1 is more basic, number 6. Number 7 is as you expand, and should definitely be there for at 18 months as your developmental skills increase. The follow-up questions to these really just delve into more details to ensure that you have truly answered that. And when the physician writes no and regards it as a point towards that risk, they are sure about that point. If perchance you didn't make it at the 18-month visit, remember the 2-year visit is right around there. So let's say you decided to go to a health center at one point and then switch back over to a private office, or for some reason you just weren't in the country or you didn't go to the 18-month visit. The 2-year visit still remains a perfect opportunity to track development, reevaluate any kid where there was a concern, and evaluate any kid with a language concern. The MChat can be administered. One good thing is that somewhere around there, some kids are getting ready to be placed in school, and everybody likes to have that passport fully stamped out to say they've received their immunizations. So most people will attend that 18-month to 2-year visit. Next, we go into our entry into the school system. As I said, we're getting ready for school medically because we've gotten all our immunizations and we're getting there. But entry into the school system, that kindergarten years, those basic school years, provides another opportunity for identification. And that's where our teachers come in. So our teachers need to know what kids would look like from an earlier perspective, but they also need to know what the kids will look like a little bit later. And it's a lot of the same. It may be literally the same with no language, but it may be that you get some kids who have more skills, but they're still not where it should be. So we talk about language not being as expected compared to other kids in the class. Parents will say they know a lot because they can hear them counting and saying their ABCs. But if you were to ask them the question, show me the letter A, or can you say your ABCs to me? They would not participate, or they would participate when it's on their own terms. They may describe the child as not socializing, they're a loner. Parents need to be careful and look at the words that are used, the descriptive terms. We're not trying to hide it, but we need to be able to address it for the parents to recognize that you are having some concerns where this is. Doesn't eat the lunch provided. Everybody sits at the table during lunchtime and they eat chicken and rice. Mom, could you please send his formula in a bottle? Because that's the only way he'll take it. Not a good example, insistence of sameness. Only plays with the number alphabet charts, doesn't play with the other kids, doesn't join circle time, only plays with the number and alphabet charts. Again, another concern. Maybe sensory seeking, sensory avoiding. Sensory seeking, you see them mouthing objects, putting things in their mouth, rubbing their hands on the surface, or when the bell rings, it creates chaos. And so we have to move him from out of the class. An easy way, if don't need to ring the bell, don't ring the bell, or warn the kid that you're going to ring the bell. flapping when excited or jumping up and down. And then the tantrums that may emerge. You're going from morning prayers, the circle time, the drawing time, to break time, and every single transition brings about distress for the kid. So teachers can also help to identify kids who may have symptoms which may be suggestive of autism. It's not that you are saying to parents your kid has autism, but features which have brought about concerns to you. Because when you look at all, in my ideal world, 15 kids in your class with 2 teachers, you notice that little Johnny over there is different from the rest of the kids. Now, I've kind of put everything on one side, and then on the other side, I've written down little professors. And remember that autism spectrum disorder uses the word spectrum. It's not black and white. It's not either or. You have a range of skills. And so whilst you may not get a kid who is verbal, on the other hand, you can get a kid who's verbal. And these are usually now the little professors. They take charge. They tell you what to do. They correct you if you're wrong. They're organized. However, despite having all these skills of being almost mature enough or older than their age, they don't relate well to their peers. And we must remember that comparative norm. Whoever it is you are comparing your kids against, it's against kids of the same age. You do not need to get along with the teacher better than you get along with your peers. Your peers are who you're being judged among. So doesn't relate well to peers. You need to worry about having meltdowns. And they are missed oftentimes simply because they have language. They may be doing well in school. And so it's kind of put on the back burner about the little behaviors because it's not right in their face, but it still causes for concerns because those little behaviors, not being able to relate, not being able to transition, those are going to build and become bigger problems later on. Once there's a suspicion of having an autism spectrum disorder, then there is need for a referral process. And everybody has a different referral process for their own country. Here, I haven't gone into how you get from a health center to a main hospital down to the Child and Family Clinic at UHWI. And I've listed this main one because this is the public referral system. Child and Family Clinic is held at University Hospital of the West Indies. It provides diagnostic services for kids with developmental disorders. Your teacher can refer you, okay? Your GP, a nurse, anyone basically could refer you, and parents could even come self-referred. It's not that we turn away referrals. It's now you understand why a waiting list becomes very long. But just about anyone who's a provider of services for kids can provide that referral to you. At the intake, parents say it's long, and remember, it's a teaching hospital as well. So usually we have a pediatric resident who will sit down and take a history. That includes listening to your concerns first, identifying any risk factors, and gathering the symptoms. And remember, the symptom state, you must meet all the criteria on one side, and you must have examples of at least 2 out of 4. And so they're going to go through this process. It will be a little lengthy. It may result in that after the history is taken, there will be a discussion within a group, sometimes or with 2 other persons and myself, was to make sure that if we were to say to a parent, we think that your child meets the clinical criteria for an autism spectrum disorder, we are sure of what we're saying. We're not guessing, because a diagnosis brings about distress. So we ask you to wait with us for that time period. Also, we start preliminary investigations just as needed, and referrals to interventional services are done on that first day of meeting. An assessment date is provided. I won't tell you what the waiting list looks like for the date. However, we try our best. All the kids we try to fit in as best as possible because we know there's the issue for transition to school, and the parents and the kids return on that specified date for the assessment, but continue their follow-up within the clinic setting. People might ask, why continue follow-up then if I already have a diagnosis? Simply because autism doesn't occur by itself, and there are going to be a multitude of other problems and challenges that will come around, and we hope that we will be helped. We will be able to guide you. Now, when we look at data, and this is unpublished data coming out of the Child and Family Clinic between 2019 and 2022, that should be, we noted that we had approximately 472 patients that presented during that time period. 77% of those presentations were that of an autism spectrum disorder. Okay, so we have some amount of knowledge as to how many are coming. And despite that, we think it's an underestimation when you compare it to CDC rates. And also when we recognize the areas that you're servicing. Approximately just under 50% of the population resides within Kingston and St. Andrew, yet we see over 3/4 of our patients coming from Kingston, St. Andrew, and St. Catherine. So 50% living in that area, but 75% thereabouts are coming from that area with an underrepresentation from the other parishes.
Hi, Doc. Wonderful presentation, but 1 minute left.
When we look at prevalence of ASD, no, it varies worldwide, and the prevalence varies substantially across studies with a global increase in the prevalence rate. Geographical variability, not only between areas, so not only between the Caribbean, but within parishes, we would anticipate. The last prevalence rates were provided by the CDC were in March of 2023, which stated that there were 1 in 36 8-year-olds. And that means that they have clinics or sites that they count children when they're about 8 years of age, see who all fits that definition, and whoever fits that definition would then be considered 1 and added to the prevalence calculation for all kids born in that particular year. So 1 in every 36 8-year-olds in the US were identified with an autism spectrum disorder. I guess I'll stop there then. If there are any questions.
You can just conclude your.
Okay. I said before that there are comorbidities. Autism does not come by itself. We need to recognize that there are simple issues: sleep, constipation, ADHD, epilepsy, anxiety, and all of these will contribute to how the child presents. There must be a multidisciplinary approach. There's about 80% that will present with 1 or more of these symptoms, and psychiatric diagnosis as they get a little older will occur in approximately 10%. Intervention, we look at the need for early intervention. We look at the goals for early intervention. We looked at ABA, recognizing that whatever intervention that you looked at must have some scientific basis. You must know how you're going to deliver it. You're going to need to know whether it was successful or not so that you can adjust it. And there are studies that reflect that ABA can work. Speech and language services, you must look at augmenting and alternative communication, especially for children who are not able to speak. To look at general developmental services, occupational services, school, and then we need to look at parent-mediated interventions. When we look at outcomes, you need to recognize that outcomes really look at what a kid would look like 5 to 10 years from now when you compare them to a normative sample. So again, peers at that age who would not have a diagnosis. And you look at developmental factors for outcome, language and communication predictors. Really, in summary, autism has clear diagnostic criteria. Symptoms are present by 18 months of age, but maybe they're earlier. Parents need to insist that concerns are heard and screening done, and early intervention is the key, though we do recognize that resources are scarce and outcomes depend on multiple factors. A diagnosis is the beginning of a journey. Thank you.
Thank you so much, Dr. Garbut. That was literally a mouthful, and I'm sure that the parents and teachers really appreciate this detailed, comprehensive presentation, empowering them in terms of how to identify if their child might have autism and what to do. Thank you so much again, Dr. Garbut. There are some questions here that we would like to run into. How do you determine slow growth versus autism? I think that's global developmental delay versus autism.
So global developmental delay in terms of a clinical definition just refers to delay in the developmental domains, gross motor, fine motor, language, and social skills. That's a basic way of putting it. However, really, the global developmental delay also compares it to a normative setting, and there is testing for that. Global developmental delay does not include in its definition the presence of repetitive or stereotypical behaviors, and it doesn't include impairment. There might be slow progression of language, and so your language skills are behind, but it doesn't describe a kid who is not trying to engage, trying to be a part of a group. So it's two completely different things, however, they often coexist.
All right, thanks, Dr. Garwood. And another question is, what causes regressive autism? I think that's the milestone regression.
So we're not quite sure what causes regression in milestones. There's nothing called regressive autism. In some kids, you get slow progression and then the onset. In some kids, you get typical progression and then you get regression of your milestone. And it's not unusual to have that presentation done. That regression is usually associated also with regression, not only in language and social skills, but also you start getting your picky eaters somewhere around that time period, where that insistence on sameness and moving away from and beginning of that social communication impairment occurs. There are other reasons for regression, and as such, when you have a regression as a presentation, you really should be seen to determine the extent to which you will do investigations.
All right, and this other question is asking, what is MChat program? And another person asks, is the MChat for older kids? You could
So the MChat is referred to as the Modified Checklist for Autism in Toddlers. With follow-up questions. It really is a screening tool to be used by individuals who have been taught on how to use it. So you can use it as a parent, but as I said, always go over it with your physician. It is done for children between 16 months to 30 months of age, and it's not valid for outside of that age group.
All right, so two parents are asking directly about their children. My son is 4, going to 5 in December. However, he's not speaking as he should. He points a lot, plays a lot, always talking and communicating, but most times what he's saying are not words that are clearly understood. Could you shed some light on what might be happening with my son? And the next person says, my son is 19 months old. He only says some letters and sounds when he's watching educational video. But what I also notice is that everything you give him, he would try to spin it. And once it can spin, he is fascinated with it. Is this a symptom of autism?
So to the latter question, I would say, please visit your general practitioner, your pediatrician, or find yourself in Child and Family Clinic and get an appointment. Start making your appointments to early stimulation program, but start having that discussion with your practitioner because those are concerning. To the former person, anonymous attendee, just to recognize he points a lot, plays a lot, always talking and communicating, but most time what he's saying are not words that are clearly understood. Remember that so there are several red flags in there, right? By the age of 4, you should be clearly understood. You don't have to be grammatically correct in every single thing. You can be using patois, but you should be clear. That alone should prompt you to seek attention. I can't tell you anything else about that. Plays a lot, talks a lot, communicating. But if you don't understand, I'm not sure how it goes in terms of communicating and talking. So that has to be explored. So for both individuals, I would urge them to see their pediatrician.
All right. Some of these questions are asking about the daytime referral process. So the association will put together a resource list, and all the persons on the platform would have registered with an email. So that will be emailed out to them. And some of the other questions will be answered later on in the webinar. One other thing, comment or question, the teacher says a lot of children in our class have symptoms in keeping with autism, but the parents are in denial. How do we deal with that?
Teachers have said this quite a bit and stating that parents are very defensive. I do think that schools need to have a reporting protocol. In fact, all schools I know have a reporting protocol. And if the teachers feel that they can't have that open discussion, then they should go through that reporting protocol. Teachers are not trying to give a diagnosis. They're saying to parents, and parents need to notice that there is something different about your kid. I'm not saying that he has a diagnosis, but I have concerns which may impact his learning, how he gets along with his peers in his classroom. And so we would like for you to please explore it with your pediatrician, or they can provide the referral directly to Child and Family Clinic. But it's the way how the message is delivered, because you need to recognize that giving a diagnosis of just about anything, in particular autism, comes with it a lot of repercussions of what may not occur, who's to blame, or just fear because of what it is not known what exactly causes it. So we have to be mindful as caregivers as to how you give that information. And we do it every single day in clinic. But for teachers, it has to be that there is a reporting protocol and the approach to the parents. Some parents will be easy, some parents won't. You can guide, but beyond that, there isn't anything much that you can do.
Thank you so much again, Dr. Garbut. Let us all put our hands together for Dr. Garbut. Thank you. Now we'll move on to our next presenter. She's from the Jamaica Association for Persons with Disability, and Miss Adrienne Pinnock will now present to us on what the association has for persons with disability, in particular persons living with autism. Over to you, Ms. Pinnock.
Doesn't look like Miss Pinnock is online. Hey, Doc. So, Dr. Morris, I'm not seeing Miss Pinnock online. Perhaps you could skip to the next presenter until she gets on. Not sure if it's
Right.
internet or anything like that. So our next presenter would then be Mrs. Simone Smith Francis. Let's see, is Mrs. Smith Francis online? No, not with us as yet either. So then we're gonna ask Mrs. Josiah Lawrence Brown to go next, who is from Sam Sharp Teachers College Diagnostic Center, who's speaking on diagnostics and early intervention. Mrs. Josiah Lawrence Brown, are you there?
Yes, I am here.
Wonderful. Thank you so much. I would love if you could go ahead a little bit earlier than planned, but we'd love if you could share your presentation with us just now.
All right, will do. Good morning, everyone. You can just give me a thumbs up if you're able to view my presentation.
Thumbs all the way up.
Great. So I am Josiah Lawrence Brown, and I'm presenting on behalf of Sam Sharp Teachers College Diagnostic and Early Intervention Center. And the focus of the presentation is understanding the role of psychoeducational assessment and support for autism spectrum disorder. We agree that Dr. Garbutt gave a wonderful and very informative presentation, and she spoke a lot about diagnostic services and intervention services. The Diagnostic Center at Sam Sharp Teachers College focuses on diagnostic services, and so we'll get right into that. The aim is to describe the service that we offer and to explain its role in providing support to children and to parents, to families who have children with autism. It's a fairly new center. We were established in 2018 to meet the demands of psychoeducational assessment for children in Western Jamaica. For years, the scope of psychoeducational assessment in the island was limited to perhaps Kingston and to other areas. And so now we have the center providing this assessment to the Western region. Our two main services are psychoeducational evaluation or assessment and remedial academic intervention. For assessment, we take walk-ins, so we do individual assessment. Parents may come in with a referral. We also go into schools based on the request of the school, and we call that our school-based assessment. We have other services, secondary services. We provide training for teachers. So we'll host workshops, professional development sessions. We provide training on instructional strategies to use for children with a variety of disabilities. And we are able to host students who require practicum experience or internship. As we zero in on psychoeducational assessment, I just want us to pause and say, what exactly is this? A psychoeducational assessment is designed to answer questions such as, does the child have a learning disability? Does the child have an intellectual disability? Are there attention problems? Does the child have autism spectrum disorder? It also addresses concerns of weaknesses in the child's academic performance. It looks at strengths as well. So strengths and weaknesses, the learning profile of the child. It also looks at what are appropriate educational recommendations. What is it that the child needs in terms of support for him or her to perform at their best in the educational environment? What accommodations are needed? Essentially, a psychoeducational assessment is a comprehensive evaluation, and it is designed to measure a range of competencies and areas. So it's not just testing, it's an assessment which includes testing and interviews and collecting background information. It's quite comprehensive, and we look at a broad spectrum of areas, developmental areas, in order to understand what is happening, what support is required for the educational environment. So it helps to detect mental health conditions that may result in poor school performance. Now, privately, clinical psychologists often provide a psychoeducational assessment, but at the Diagnostic Center at Sam Sharp Teachers College, we function with what we call a multidisciplinary team, a diagnostician, and a clinical psychologist on staff. Each member of the team is an assessor and will meet with parent and child once an assessment is scheduled. And when the assessment is through, the team meets again, each person sharing their knowledge, their expertise, what they would have observed, their conclusions from the assessment, and then we give a final diagnosis. In terms of the procedure, what it looks like for the Diagnostic Center is that it begins with identification. So parents sometimes walk in and say, I've been doing my own research. Someone has spoken to me. A teacher has said something to me and I've looked it up and I think my child has autism. So parents often walk in. Sometimes teachers refer the parents with their children, sometimes the referral may come from a healthcare provider who has noticed signs of delay. We find, though, that many of the referrals that come in are for delays in speech, delay in language, and sometimes that symptom is not accompanied by any other symptom. As Dr. Garbett would have mentioned before, that we look out for symptoms of restricted repetitive behaviors. We look out for social deficits. So not just a language deficit or a language delay, but we find that many of the referrals come in with that sole symptom that the child is not yet speaking, which is cause for concern. But what we do then is to ask the parents, if they do not come in with a referral from a medical doctor, to visit the pediatrician, especially when the child is under 5 years. Visit the pediatrician, go get a hearing test done. We want to rule out these things. So once you go to the pediatrician, it's likely that the pediatrician will do the MChat that we've been hearing about from morning. The pediatrician would then write what their concerns are and say, to the diagnostic center, I present this child to you to rule out for autism or to rule out for global developmental delay, and we will take it from there. So once you have that referral, you can begin the registration process for psychoeducational assessment. Now, at the Diagnostic Center, because of our affiliation with the Ministry of Education and Youth, there's no cost attached to completing a psychoeducational assessment. And so once that preliminary check is done, we provide you with the registration forms and the list of documents that you will need to bring in. And once those are submitted, you are registered and placed on a waiting list. We understand that the demand for psychoeducational assessment is quite great, and so there is a wait period. And we have been trying our very best to cut down the time for waiting as much as possible. In the process of the psychoeducational assessment, parents and teachers, you can expect that the child will be given a test for intelligence, an achievement test. So that's a test to see what is the basic level of academic functioning. Can the child read, spell, do math? There'll also be a test for social, emotional, and behavior functioning. What is the child doing socially? And specifically now for autism spectrum disorder, the assessment must include an adaptive functioning test. And this is generally an interview done with someone who spends a lot of time, a caregiver or even a teacher, someone who spends time with the child and can report on the child's independence in doing practical skills, taking care of themselves, how they socialize, how they communicate. So that adaptive functioning test must be done once it is an assessment to confirm the presence of autism spectrum disorder. So as a parent, if you have done an assessment somewhere and you want to utilize it to get the benefits of an assessment, you can look out for this testing being done as a part of the battery of tests. And another thing that will be associated with identifying autism spectrum disorder in the assessment phase is the use of developmental testing, either the ADOS, the ADOS tool, or the CARS tool, CARS Childhood Autism Rating Scale. So both of these are just examples of instruments that the assessors would use to screen for symptoms of autism in all the different diagnostic criteria. So the initial screener that the medical doctors would use and that parents can sometimes utilize, as Dr. Garbett shared, is the MChat. Then as a part of the psychoeducational assessment, in addition to the intellectual test, the achievement test, the test for social, emotional, and behavioral, in addition to the adaptive functioning test, the psychologists or the assessors will also utilize a tool for identifying symptoms of autism. So that's another thing you want to look out for and to expect that a tool will be used to find out what is the child doing. A standardized tool, just the same, looking at all the different criteria or diagnostic criteria of autism. Now, what is the benefit We notice that in the term psychoeducational assessment is the word educational, because this sort of assessment should help to provide support for school purposes, support for educational purposes. So very basic, it helps to provide a diagnosis. And a lot of parents come in very early to us, and one of the things we do is help the parent to understand this journey through autism, that you may see signs, you are referred, but when you come to the center, our main service is a diagnostic service. And so after diagnosis, as Dr. Garbutt mentioned, it's only the beginning of the journey. The next step would be to get intervention services. So sometimes parents may think that you have to wait until you have diagnostic service to begin intervention service, and that is not necessarily so. If the intervention service does not require a diagnostic report in hand, you can begin intervention, begin language stimulation, approach a speech therapist while you are coming for diagnostic services. The diagnostic service can inform recommendation for other therapies, but just the same, persons at early stimulation who provide intervention service, they do their assessment before they begin intervention. Speech therapists also do their mini assessment before they begin their speech therapy. So you can explore intervention services while you wait on the diagnostic service. Another benefit is that it informs appropriate school placement. So once you get the report, we do a feedback session with you. We're able to share with you different classroom settings or school settings that may best help the child. We also inform appropriate accommodations. Does this child need shadow? What sorts of behavioral support would benefit this child? What sorts of sensory processing support do they need to try? Noise canceling headphones? Do they need to be stimulated each day? And finally, the assessment also helps to determine eligibility for financial assistance and therapy. So when the other organizations share with you, they'll share the list of benefits that you can get from the Jamaica Council for Persons with Disabilities, as well as from the Ministry of Education and Youth. What the assessment does, it explicitly states that this child has autism or not, and these are the services that are needed for this child, specific to the presentation of autism in this child, because each child is unique. And then once you have that document, you can use it as a tool to access benefits from the organizations. And so finally, I intended to be very brief. This is our contact information. We are located in Granville, St. James. And we do take walk-ins and we follow the procedure as was explained before. So our contact number and our email address is on screen. If you wish to access diagnostic services, you may walk in to collect the registration form. You may call ahead and have a discussion with us on the phone, or you may contact us via email. Thank you so much.
We want to thank you so much, Mrs. Brown, for that excellent presentation, empowering presentation. And we are happy to hear that in the Western region, there is this organization that has come on stream to fill such a significant gap in the Western region, underserved community. And I'm happy that that gap is now being filled. And we want to thank you for your excellent work. I see some questions in the chat. Let me, I will wait until after the other presentation because it's of a similar kind that we'll take the questions.
All right.
We now go to our next presentation, and this time it's from Psychocare Center, and our presenter is Ms. Simone Smith-Francis. She's a social worker at the Psychocare Center, and she's here to present to us on the services offered and how to access those services at the Micah Care Center. Over to you, Mrs. Simmet.
Apologies for the confusion. So I think our next presenter is actually Miss Adrienne Pinnock from Jamaica Association for Persons with Disabilities. Ms. Pinnock, I see that you're here. Can you unmute for us, please, and start your presentation? Thank you so much.
Good morning, everyone. Are you able to see me?
Yes, we're able to see you.
I
Wonderful
must
hat.
give some clarity for my attire. I am at a funeral, but I could not miss the opportunity to share with you the information about the Council for Persons with Disabilities. Thank you for extending such an invitation to the organization that we are able to share in this way. But I will have bad news and good news. The information I share about the services are not readily accessible tomorrow. We had to put our programs on hold because they have been oversubscribed. However, the rehabilitation services of the council is the main vein of the organization. And as soon as we are able to honor the oversubscription we have, the programs will be then made available for accessing of the persons who are so in need. I am sharing my screen, but I'm not sure what you are seeing. Could you confirm seeing my presentation?
Not your presentation yet. You need to, we're seeing Zoom. So if you come
We're
out of
only
Zoom
seeing Zoom,
there,
so I have to come out and go back again.
no, ma, if you minimize it and go to the PowerPoint, it would have worked, but sure. So click on share, and then you should see your PowerPoint as one of the options there.
I was trying to find that, but it was not. There we go. All
There we go.
right.
Yes, here it is. Perfect.
Okay, great. So
So we
my
just
name,
need you
as
to
I
go
was,
to the presentation view now. Put it in presenter view for us,
it
please.
is in that option on my end. You are not seeing it on yours?
No, we're seeing your PowerPoint, not presenter view.
All right, hold a second. Let me do this again. Stop sharing.
No, that's okay. And we want to thank you for taking the time out and, of course, extend our condolences for the loss. You know, you said you're at a funeral. So we thank you for making the time for teachers and parents and everyone that's here. Everyone, please give her a thumbs up for making every effort to be here for this presentation for us today. All right, so we're not seeing the presenter view, but because of your time and your situation, please go ahead with your
I think I'm
presentation.
going to proceed. I hope you can see
Yes,
the screen nonetheless. You are able to
yes,
see
we
the
can.
screen?
Yes, we can.
Okay. Okay, so the services I'm about to share with you are that of the Council for Persons with Disabilities. And as I was introduced, my name is Adrienne Pinnock, who is the organization, the Jamaica Council for Persons with Disabilities. We were a department of the Ministry of Labor and Social Security. I tend, when doing these presentations, to bring to our attention that we are a brand new second hand. So the organization was really established in 1973, but on February 14, 2022, the Disabilities Act coming into full effect gave the organization a new authority, and we are now what is called a body corporate. So we are no longer a department, but we are a body corporate that reports directly into a board of management that reports directly into the minister. So we are establishing with that authority to support the welfare and to promote the rights of persons with disabilities. Our core values, we have some things that make us up as who we are. We focus on equal opportunities for persons with disabilities, and I dare to say equitable opportunities where applicable. We are supportive in the empowerment of the lives of persons with disabilities. We believe in service excellence and collaboration. We have a tagline that we say, see people and not necessarily their disabilities. And I want to move quickly to who the Disabilities Act define as a person with a disability. And the Disabilities Act defines an individual who has a long-term physical, mental, intellectual, or sensory impairment that may hinder his or her full and effective participation on an equal basis with others. So that's who the Disabilities Act indicates as an individual with a disability. There is a debate that persons who have autism, because it's a developmental disability, their category is not represented there. But yes, they are, and persons who are on the spectrum are considered persons with disabilities and can be registered to benefit from the services that we have. I am describing to you the rehabilitation program of the council, but as the Disabilities Act comes into full effect, there are other services that the Act will dictate that we have. For example, the Disabilities Act instructs a confidential registry to be operational through the organization called the Jamaica Council for Persons with Disabilities. This confidential registry is voluntary for persons who fall in the category of the definition of persons with disabilities to choose to be registered with the organization. Once you are registered, you are noted on the confidential registry. It then gives you direct access to the rehabilitation program. Other services are not necessarily tied to the registry. For example, if you have experienced discrimination, under the Disabilities Act, you can receive redress, but you don't necessarily have to be registered to access the redress of discrimination. We encourage it, but you cannot be barred from accessing that service because of lack of registration. However, the rehabilitation program, though, you would be required to complete the registration process, that your disability is verified and you are noted in the registry to access the services I am about to describe. The services I described, though, as I said at the start of the conversation, they are on hold because they are oversubscribed. So the council and none of our services are limited or barred from any one disability group. Once you meet the minimum criteria, it doesn't matter the nature of your disability, the service can be made available to you. You have some persons, however, where their families have to access the services on their behalf. I should go back to the top. What constitutes registration? We have some prescribed forms that you would be required to complete. In the presentation before, for persons who are on the spectrum, a psychoeducational assessment report is what is used to verify your disability. And we have a medical form that you would take to these diagnostic centers, Sam Sharp being one of them, to have it completed so that the disability is identified. Then there is an application form that's completed by the individual if they are so capable, and if they are not, a family member or a caregiver or a parent may complete those, and they are submitted. Once a disability is identified, the documentations are admitted in our registry. When you are registered, our rehabilitation program is broken into income generation and educational assistance and assistive and medical support. That's how it is broken. You will see on your screen the facilitation of income tax exemption under the Income Tax Act. That process is on hold because of a revision. Once it is finalized, it opens now. It is made available to persons with disabilities who are contributing to income tax to make an application for consideration of exemption. We have a Margaret Moody Scholarship Fund that will become available in July for persons to apply. It supports you for tertiary level education. It is a competitive scholarship where 2 applicants are awarded each year to access tertiary level support. The support through the National Housing Trust. There are many benefits through the National Housing Trust for persons with disabilities. There is a grant an accessibility grant that is made available for making your home space retrofitted for access. Through your registration with the council, you can access such a grant with the NHT. That particular service is still available. What you can apply for your verification letter to take to the National Housing Trust for the retrofitting. There is also a benefit of a discounted mortgage as a person with a disability if you're purchasing NHT housing solution. There is also benefits if you're purchasing on the open market. We have an ID card that is offered to our persons who are registered. It comes at a cost of $500. That service is available, and you can utilize the card as one of your verification for disability, where the transportation system operated by the government is in place. In Kingston, it's the JUTC. I'm not certain what it's called in the Western region. You can utilize the card to pay a discounted bus fare. We are aware, though, that while the services are not island-wide, it is one of the operations in the new structure of the rehabilitation program to strengthen these services that you see being offered. So in short order, you will notice that the council will have a robust public education to educate the public about the strengthening of our services when we open back up for intake. We have a program called the Economic Empowerment Grant. We now are oversubscribed, so these services I'm about to tell you, they are on hold so that we can satisfy the applications we have. This program is specifically designed to help persons with disabilities and or their families to operate a business where there is a low income in the family or the absence of an income. The idea or the purpose of this grant is to improve the independence of the individual with a disability. Where there is an individual who is unemployable, the family can access the benefit so that they are able to better care for the individual and they can live a dignified life. We have an assistive aid program, and under this program, therapeutic services can be accessed. It too is oversubscribed, but it will soon open back for service. So it offers the hearing aid support, the mobility support under the prosthetic limb support, therapies, occupational therapy, speech therapy, all of those therapies can be accessed under this grant. You would have noticed that last financial year, there was a partnership with the Ministry of Health, and we offered a program called New Life, New Limb. Based on the response and the need, there is still a thinking for that program to also continue. There is what we call an emergency fund based on the population we serve. You have some persons with disabilities who don't have the support of families or even a community, and there are instances where there are some socioeconomic needs that under the emergency fund, the council will seek to assist the individuals. We have medical assistance that also falls under the assistive aid program, and we can support in purchasing prescription, support you for some of your medical expenses like surgeries, not cosmetic surgeries though, but surgeries, dental care, and that type of services persons may access. How do you become eligible? You first have to choose to be registered with the council. Each service we have under the rehabilitation program has its independent application process. So registration is just what gives you access, but for each service you require, you would have to choose to make an application for it. Or social workers conduct an investigation, which will allow them to prepare a report. And from that report, a committee reviews the application, the investigation report, and a decision is made for support or not support. If you are not supported, it will be indicated to you as to why, and you can choose to reapply or what you call appeal the decision. Where the council cannot support the need that presents itself to us in our social work department, we have a referral program where we will route persons to other entities that can provide the support that they require. And on screen, you will notice the NIS program, the PATH program. There are other groupings of or organization that serves persons with disabilities that persons can be routed to. A thought just came to me that you may be considering, what if I have multiple disabilities? You can access our services nonetheless. And the list continues: the Jamaica Association for the Deaf, the Community-Based Rehabilitation Jamaica, the Child Learning Center and the Microcare Center, the Surgeon Golding Rehabilitation Center. How do you reach out to us? Our head office sits in Kingston and we are located at 10 Ripon Road. However, through the Ministry of Labor and Social Security offices island-wide, we seek to reach our clients in different parishes. Some parishes have a social worker that sits there each week. Other parishes, we have a special day to which we turn up to offer the services to the persons. If you want to get some information, we encourage you to reach out to our head office. I will send the presentation to the organizers so that our contact details can be shared with you, but you can reach out to us on our numbers, and our website will have further information, and we have the email address listed there. We are also on social media. We encourage you to follow us at JCPD on both Facebook and Instagram, because there the services are also listed, and there is a social marketer who will interface with you if you have questions or further details. All the services we offer are free of cost. Nobody is to be selling any services of the council to you. The only service that there is an additional there is a charge is that of purchasing the ID card. There are no services that come at a cost. So if you encounter someone who is selling you an application form for the empowerment grant, or they are selling you an application form for any medical assistance therapy, you are encountering somebody who is doing something unscrupulous. The only service that there is a fixed charge is that of the ID card. And we encourage, if you so desire, to make use of it. I thank you for the opportunity to share with you in this way. I have to go because of my obligations, but as I said before, the council is at your service, and we can be reached at our numbers if it is that you have further questions and is in need of clarity. I will share the presentation for ease of reference, but just so that you remember, our services, the rehabilitation program is on hold, and we will open soon to be better able to serve our growing population and those who were already members of ours. I do wish you all the very best as you gather the information today. And if what you hear is not directly relevant to you, once you encounter someone who can make use of the information, we encourage you to share same with them. Thank you so much.
Thank you so much, Ms. Pinnock. And again, our deepest condolences to you. And we really appreciate you joining us today. And the parent and teacher and everyone online truly appreciate you. Thank you.
I think Dr. Morris, now we'll welcome Mrs. Simone Smith-Francis.
Right.
All right, perfect.
So we now make way for Mrs. Simone Smith-Francis from Microcare Center. Over to you.
Thank you, everyone. Give me a second. All right. Good morning, everyone. Thank you so much for your introduction. And thank you also for inviting me on this platform so I can sensitize your audience as to the operations at the Microcare Center. So throughout my presentation, we'll be going through a brief history of the Microcare Center, the services offered at the center, our clientele, the multidisciplinary team approach that we use, the assessment process, indicators for referral, autism screening organizations, support agencies, and schools. All right, so the Microchild Assessment and Research in Education Center was established in 1981 to meet the needs of children requiring special education in Jamaica and the English-speaking Caribbean. It provides diagnosis through assessment and remediation of children with learning problems. We provide clinical practice for special educators and psychologists in training. We provide support to parents and teachers for students with special education needs and disabilities through publications, coaching, and counseling. We also provide training and other forms of professional development for educators. What is our vision? Our vision is to create a Caribbean region where students with learning differences are inspired to achieve their full potential through access to quality learning solutions supported by sustainable educational policies and practices grounded in culturally relevant research. And what is our mission? Our mission is to be a model organization working in partnership with families and educational stakeholders to create sustainable, positive outcomes for children with learning differences through diagnostic assessment, research, innovation, data-driven intervention, public education, and training. So we currently have 3 branches in operation. Our head office is located at 5 Manhattan Road, Kingston 5. And there are the contact numbers. We also have an office in St. Anne. It's located at 2 Roy Street, St. Anne's Bay. And you also have the contact numbers for that branch. And we also have a branch in Mandeville. It's located at 53 Main Street, Mandeville, Manchester. So let's look at the services that we offer at the center. So we offer psychoeducational evaluations, field assessment, and field assessment is, let's say a school has a particular group of children that they want to get assessed. The school administrators can contact us and we make the necessary arrangement to send our clinicians out to that school for them to get a field assessment done with those students. We also offer medical and hearing screenings, academic remediation, training. Trainings take the form of seminars and workshops for teachers and parents. We offer training in our micro-diagnostic reading test, the 2nd edition, practicum supervision. We also offer development of culturally relevant diagnostic tools, and we also offer educational research and public education. Let's look at our clientele. So our clientele are children between the ages of 4 to 18 who are 1, failing in school, who display behavioral challenges, emotional and behavioral problems, which are inhibiting learning, children who have learning and social disorders. We also offer speech evaluations and interventions, beginning with children as young as 2 years. Our clientele are also parents who need guidance on child development, behavior management, and parenting skills. So we use a multidisciplinary team approach at the Microcare Center. Our assessment teams are comprised of a psychologist who is a case manager, a special educator, social worker, and also the nurse. Special cases, we also have a speech therapist on staff and occupational therapist when available. So let's look a little into our assessment process. So the first stage is registration. Second stage, intake, phase 1 and phase 2. The third stage is scheduling and testing evaluation. Then we move on to report generation, editing and dispatch. And then we have case conferences and parent conference and feedback. So let's delve a little deeper into each of the stages. So for registration, forms are available online or may be collected in office. Parents may self-refer. So if as a parent, I realize that my child has certain challenges, I can use my initiative and say, okay, let me visit the Microcare Center and let me see if I can get my child assessed, right? So that's self-referral or be referred by a third party, okay? So this could be the child's teacher or the child's doctor or even a family friend. Parents or guardians should submit completed registration forms along with 1 passport-size photo, a current photo, their immunization card, birth certificate, most recent school report. A file is created and submitted with the documents and processed during intake. Now, our intake process, there are two phases, intake phase 1 and phase 2. Phase 1 is done by the social worker, and the social worker will conduct the preliminary evaluation of the file details and distill this information into a comprehensive statement of referral. Phase 2 is done by the case manager or the psychologist with the support of the multidisciplinary team. They will review the information and determine the suitability of the cases for assessment. Accepted cases are submitted for scheduling, and rejected cases are referred to more suitable agencies for support. All right, so we're now at scheduling. So clients are scheduled primarily by order of registration, so on a first come, first served basis. Exemptions are made for urgent cases, which include students who are sitting their PEP or CSEC exams, court cases, children who have suicide concerns, and children who experience trauma. All right, testing and evaluation. So this is the full process now. So social investigations are conducted by the social worker. These investigations are carried out with the child's parent or guardian. So we'd like to get a feel of the child's social background, their relationship with their peers at school, their relationship with their family members, so on and so forth. The medical investigations are done by our nurse, and she will just collect all the medically related information about the child from the child's guardian. The cognitive and behavioral evaluations, these are conducted by our psychologists, right? So we like to get a feel of their cognitive functioning, how they think, how they reason, how they make decisions, right? And the academic evaluations are done by our special educators, right? So they will go in more details into the academic portion. So we like to see how the child is functioning in reading, in writing, in math, problem solving, things like those. All right. So at the end of the assessment, we have a case conference. So all the clinicians who saw a particular client or case will come together as a team, come with all the information that we got, and we come up with decisions and recommendations. So the team meets to discuss the findings, recommendations are made, findings are then discussed with the parents and the teachers where possible. So we do that in a parent conference, all right? Report generation, editing and dispatch. So written reports are generated detailing all assessment findings and recommendations. Reports are submitted to the records department for editing and dispatch, and the turnaround time and evaluation for the parents to get the reports is around 4 to 6 weeks after the assessment is completed. So let's look at the interventions that we offer. All right, so appropriate recommendations and referrals following assessments. We can recommend a change in the child's school placement. We can recommend remediation for the child, and we can also recommend therapeutic intervention. Remedial intervention. So we also offer a remedial intervention program at this center. This is a short-term program for 1 term, where the child is pulled out of their school. They will come and attend classes at our center 4 days for the week, and then on the Friday, they will go back to their school. So that's done for an entire term, okay? Our trip program, this is our evening program, our evening programs where children from other schools will come for evening classes, right? Geared towards finding solution to their need or specific challenge. All right, we also have the Bridge program, also our special education program. This provides suitable placement for children aged up to 11 who are slow learners or who have been diagnosed with a specific learning disorders. All right, so there's also a special education unit at the micro-practicing primary school, which is next door to the care center, and they facilitate children between the ages of 7 to 9 years. And we also offer counseling support for children and their parents. All right, so let's look at some key indicators for referral. Children who are referred to the Michael Care Center exhibit challenges which may indicate that they have special needs. These challenges may include academic or cognitive deficits, behavioral challenges, social emotional challenges. All right, from indication to intervention. It is important that teachers, parents, and other stakeholders know what indicators are considered problematic to facilitate early intervention. So we need to, as parents and as teachers, to be able to recognize the red flags from early so that these children can receive the intervention and the support that they need. So academics. School-based interventions are often most effective in clearly identifying which students need assessment and which students need additional in-class support. Behaviors. All behaviors serve a purpose. It is important to figure out the reason behind the child's behavior so that the necessary interventions can be put in place. All right, so let's look a bit at some autism statistics. So in a Jamaica Gleaner article, this is 2019, done by Kathy Chung, co-founder of the nonprofit Jamaica Autism Support Association, autism is 4 to 5 times more prevalent in boys than girls. Of the 678 confirmed cases of children born with the condition in Jamaica last year, that would have been 2018, 545 are boys and 133 are girls, with almost half of the children having average or above average intellectual functioning. All right, so let's look at some agencies that do assessment or screenings for children with autism. So we have the Early Stimulation Program. This program, the referrals are accepted from parents, teachers, and medical professionals. It caters to children between the ages of 0 to 6 years old. The Michael Care Center, we provide comprehensive psychoeducational evaluation. We cater to children between the ages of 4 to 18 years old. The Child and Family Clinic at the University Hospital of the West Indies, Mona. They also facilitate assessment and intervention. We also have the Shelley and Fraser Assessment Center located at UTech. And we have other private agencies such as Caribbean Tots and Teens and the Kai, AD, Morgan and Associates. All right, so let's look at social parental support agencies and schools. So the Jamaica Council for Persons with Disabilities is also a support group, and they offer school grants and other support for persons with disabilities. The Jamaica Autism Support Association provides parent support and advocacy for children diagnosed with autism. We also have the Community-Based Rehabilitation Jamaica, which supports developmental assessments and early intervention. They also cater to children between the ages of 0 to 6 years old. All right, there's also the Caribbean Autism Support for Education case, and this group aims to provide awareness, sensitivity, and education to the Caribbean community through educational training and resources. We have schools like the Promise Learning Center. It's a special education facility. It caters to children or persons between the ages of 4 to 25 years old. We also have the Genesis Academy. It's a special education institution as well. They accept children at the high school level. We also have the Montego Bay Autism Center. It's also a special education institution which caters to persons between the ages of 3 to 18 years. All right, so as some of us or all of us may know that April is celebrated as or recognized as Autism Awareness Month. So at the Michael Care Center, we partner with CASE, the Caribbean Autism Support for Education. We partner with them to have a parent coaching workshop for parents who have children with autism, and this happens every April, right? So we just had one recently last month. It was very well attended, and the parents appreciated the information that we had to offer them. All right, so wrapping up now. So for more information on the services offered at the Microcare Center, you can visit our website at themicrocarecenter.org, and you can visit our social media platforms, Facebook, Instagram, and also YouTube for content, relevant content, and if there are any events that we're hosting, all the information is you can find them on those pages as well. So thank you so much for having us. Dr. Morris, over to you.
Thank you, Mrs. Francis. We truly appreciate that comprehensive presentation, well informative, and I'm sure that the parents and teachers, everybody online truly appreciate you presenting to us, giving so much information. Okay, so at this point in time, we will go into some questions. We have some in the chat here. You just go through. All right, so they're asking for the turnaround time. So Mrs. Brown and Mrs. Francis could just quickly give the turnaround time from the referral to report for your institutions.
All right, so we have a very, very long waiting list. We are pretty much oversubscribed, and we're trying our best to facilitate as much assessments as we can. But we would say around between 5 to 12 months for the complete turnaround time for the assessment to be done.
All righty, thank you. And for Sam Sharp, Mrs. Brown?
Good morning again. So we also do have a long waiting list because of the demand, and we are working at it as best as possible. Currently, we are seeing persons from a year ago. So our turnaround time from submitting registration documents to intake for assessments is 1 year.
Okay, thank you both. And interesting question for adults who might have been missed. Is there any possibility for those persons getting assessed?
All right, so as I stated in my presentation, our clientele are mainly children between the ages of 4 to 18. However, persons can feel free to get that assessment done privately, okay?
Okay, thank you. All right, so I see a question or comment here. Has there been any thought on healing or decreasing autism symptoms through natural nutrition, etc.? Are there any functional doctors with your organization looking into these research and action options? I hear test therapy. What about nutrition and brain or gut health? Can we have feedback on this? So I'll answer that one. Nutrition plays a very important role in most, if not all, disease conditions, and therefore good nutrition is something that is promoted right across the board, not just in children with autism. And there may also be nutrition challenges in children with autism, and therefore the approach is holistic. But we are focusing today on another aspect of autism, but the nutrition is absolutely important. So we'll run into our next set of presentations. So up next, we will hear from Mrs. Kashika Sinclair. She is in the Ministry of Education, Special Education Unit, Region 4. And so she will present to us today on what the Ministry of Education Region 4 offers for children with special needs and in particular, children with autism. Over to you, Mrs. Sinclair.
Thank you, Dr. Morris. Thank you, Dr. Morris. I hope I'm being heard and being seen. When I'm presenting, I'm not able to see if
yes, we're hearing you.
You're hearing me. Are you seeing me? Yes, no, okay. I see some thumbs up and things going on. I want to thank the PAJ Outreach Program for conceptualizing this very, very important forum so that we can have these types of information being shared. I beg you people, please do not stone me. I know that the Ministry of Education is doing all we can within our powers and the resources we have at hand. And we have limitations in terms of what it is we can provide, but I ask you to bear with me as I go through my presentation. And I also ask that you try to reach out to get assistance individually as we move through the changing times in our country, in the world, and with the newness of autism spectrum disorder and the different comorbidities that are affiliated and associated with autism spectrum disorder. So for us in the Ministry of Education, the focus is about identification and remediation. And before I delve into the whole business of identification, just to speak to the initial identification that is done by families, churches, schools, you know, we know that all of us are not clinical in how we operate, but we see differences. We see that a child is operating atypically. And so it's for us to go through the whole referral process that is within our school, because there is a system. There is a whole book written on identification and referral for teachers to use to help guide as they seek to get diagnosis for the students who they identify to have differences in how they behave, how they learn, and so on. Then there is remediation. And as I go through my presentation, we will see the systematic approach that we try to utilize in getting our students to get the best treatment based on the specific level of autism that is diagnosed by our different teams. So speaking of levels, we look at levels in terms of level 1, level 2, and level 3. We may also look at them as mild, moderate, severe, or profound. So those children who are at level 1, they require some amount of support, a little bit of support here and there. Some of them speak very clearly, they articulate well, they have conversational conversations, they respond yes, no, they follow with you in conversations, and they can participate well in school if they are given some amount of support. Then we have those who are at level 2 who are a bit more in need of assistance than the ones at level 1. So these ones are the ones who are moderate, so they have atypical social behavior, and some of them, you may see them walking on the toe points, flapping and so on. Dr. Garbott would have explained this, so I don't need to go into the whole clinical. But just to say, for just identification purpose in school and how it is we treat based on the different levels. Then we have the level 3, which would be the profound and the severe and profound, which requires great amount of support. And so thinking about the different levels of ASD, I want to just set that tone so you follow me as I go along. So serving our different levels. We have interventions and we have segregation. I'll speak very briefly on both. So interventions, we talk about the students who are mild to moderate on the spectrum. So we have the proficiency pathway in our primary school and primary schools, and we have intervention classes, we have individual intervention plans, and we have the alternative pathway to secondary education in our secondary schools. So the proficiency pathway, I don't know how much parents are aware. We should be, because it is very important that we are. At grade 1, the students come in at age 6, and they do the grade 1 individualized learning profile. A profile is created, a profile is generated from the responses that the students would have given to the different tests and sub-tests given in that profile, that battery of tests. And a profile is created to say these children are green, meaning they are independent learners, they come ready, they are prepared to learn. Then there's a middle profile, which is the amber profile, which speaks to the students who are not so ready, they need a little bit of help, a little bit of support. And then we have the red profile, just like our stoplights in the world. The red profile are those students who are really, really in need of help. And in this red profile are usually children who have ADHD, autism spectrum disorder, and so on. I might add at this point, though, that many of our children with autism spectrum disorder are high functioning and can actually go unrecognized, unidentified in school because they are cognitively operating well, and we miss the social challenges that they're having. We see these children as the ones who throw the tantrums, the ones who play by themselves, the ones who prefer conversations with adults and not necessarily with their peers. Dr. Garbutt spoke to that as well. So with these profiles created on the proficiency pathway in our primary schools, the children who are on the amber and the children who are on the red are given special attention. This is where the teacher now goes through paying so close attention that she determines that this one is going to need some form of intervention. And that's where the Ministry of Education will go into the school, special needs coordinators across the island, myself included, go into our schools, and we do classroom observation. We look at the anecdotal records that the school would have on these students, and we help the teacher after several visits and after several conversations to determine what intervention plan can be created for that particular student, because we have intervention plan templates created by the Ministry of Education to help guide families and schools in supporting our students with special needs, and specifically now to students with ASD. So that is for the proficiency pathway. And then it goes into the intervention plan. And if we find that the intervention plan is working, then we continue with it and increase the number of objectives and behaviors that we expect for each term and so on. Those children who are on the red, the same treatment is given, and we monitor to determine if these students are meeting the goals. And if they're not, we go through a sifting process to see those who are making gains and those who aren't. Then we go through the whole process of referral, getting them assessed and so on. So an intervention program can be created for them. And if the intervention program is not working for them, then we know, depending on the assessment report results now, is it that these students are moderate to profound? Is it that they need greater care, greater assistance? What do we do? This is where the segregation comes in. And segregation speaks to taking our children who are diagnosed with particular special needs, particular levels of disability. In this case, there's the severe to profound autism. And as I said, they usually come with comorbidities or additional challenges as ADHD and epilepsy and so on. And so this affects cognitive processing, and we will see that in the IQ scores. And so our segregated schools are equipped with all special education teachers, vocational skills training, and so on. And these schools go up to age 21 and make it ideal for these students to be treated and assisted to success in these segregated schools. So some of our segregated schools are like the Landala School of Special Education. They have the satellite, the main campus in Westmoreland, Savannah Lamar, and then we have the satellites in Montego Bay in the form of Montego Bay Learning Center and Lucy Learning Center in Hanover. Then there's Edge Hill School of Special Education in St. Anne, the Windsor School of Special Education, and the Woodlawn School of Special Education. And that is how we kind of lay the groundwork as to how to treat, how to focus on our students who have autism spectrum disorders by putting them through an intervention process or putting them in a segregated institution that is created for them to be supported more intentionally. So with this said, we look at the student, or teachers are trained to look at students as diverse learners. Suffice it to say at this juncture, not all our teachers are special education trained. So we have that challenge, which makes it imperative that every year, the special education unit in Jamaica hosts a summer training program where teachers who operate in mainstream meaning it's not a special education school, but they do have children in their classes who are not necessarily diagnosed, but they suspect that they may need a bit more support and they may have a special need. You heard from the professionals just now, the diagnostic centers are oversubscribed. So sometimes the teachers and the families do know that something is going on with the child and the child does need assessment. But because these institutions are free, they are more what people gravitate toward because it's more affordable. So the families that are not able to get private assessment done will want to go to these institutions, and it's a long wait. So the teachers, even though they recognize that something is going on with the student, may just have to create intervention programs and plans in the class and treat with that situation in the class as time goes by. And so, as I said, it's an imperative that the Ministry of Education, through the Special Education Unit, has devised what we call summer training for mainstream teachers who are teaching in regular classrooms, but have students who have special needs. So we talk about the student as a diverse learner who has different learning styles, different thinking styles, multiple intelligences and special needs. So when we look at the different learning styles for students in high schools, primary schools, any student at all, we are looking at some of them being oral learners. You may find that your child who has autism spectrum disorder learns a language easily. They hear and they're able to speak, and you're wondering, where on God's earth did this come from? Or you may find that your child who is on the spectrum draws very well, paints very well. Or you may find that the child on the spectrum has very good verbal skills or logical skills. You may find that they do math in their heads and you have to be grabbing paper and calculator. And even when you're using the calculator, they're done before you. So we look at the different learning styles that our children have. Do they learn through music? Do they learn through games? Do they learn through play? Whatever it is. And we pay attention to those and make sure that we adhere to them. Still looking at the child as a diverse learner, we're talking about the different thinking styles. Is the child a logical thinker and focuses on the facts and the bottom line? And most of our children are on the autism spectrum, especially if they are high functioning, who we used to call the Asperger's. They are very logical. It's either black or it's white. I don't know if any of you know the sitcom Young Sheldon or The Big Bang Theory. I don't know that these people are diagnosed with autism spectrum disorder, but when I watch Young Sheldon or when I watch The Big Bang Theory, I see Asperger's, high functioning autism, and they're very logical. There are no in-betweens with them. Sometimes they can be very creative as well. I don't know if you've met Martin Thomas, I think his name is. He does very good at art, and sometimes there are displays that he has at different centers, and he does very, very well. He's not a social person, but he is very, very creative. So he thinks creatively. We have those who are practical thinkers, rational thinkers. So we have to study who our children are, and just the same, our teachers have to study who our students are so that they can create teaching aids for them. They can accommodate them at their specific learning levels. We also have the multiple intelligences. No two students who are on the autism spectrum are the same. And so we can't share notes, just as though you can't try to fill out a form that requires your demographics, your personal information. You can't bend over in the person's paper and copy. It's the same thing with students on the autism spectrum. They are very different. They have multiple intelligences that make them learn in different ways. And teachers have to be fair with this. And these are the things that we make sure we cover when we have our summer training for teachers who teach in mainstream, because our children don't all learn the same. And we cannot, in classes, we recommend that teachers do grouping, but teachers can't say, oh, I have 3 children in here who are on the autism spectrum. Let me put those 3 in the same group, assuming that they have the same interest, same learning style, and so on. It doesn't work like that. We have to read the assessment reports, take the salient points from it, look at the recommendations that are usually there, and see how we can apply these recommendations to improve the learning chances of each of our students, because they are diverse learners. And also, we practice differentiated instruction. Differentiated instruction is actually a means of teaching the same content to a group of learners in different ways so that every learner has the greatest possible outcome of learning. So we are differentiating the content in terms of how we present it. We are differentiating the process that we use. So we sing at some part, we dance at some part. Some of the parts we have to get up and make them do some artwork. Some of the parts we have to work in groups. Then we also have to differentiate the product. What is it we're asking them to show us, to inform us that they have learned? So I am a logical learner. I don't want you to tell me John lives in America and he sends $20 to his family for the month. What are some of the things you think this family will buy? Now, if I am on the autism spectrum and you give me a question like that, first of all, I am not just a regular child who just look at the numbers and just work out what can be bought based on the items that are given. But a child who is a logical thinker on the autism spectrum, like I said, they see black and white, is going to say, $20 is not enough to do this, and will ask, why did John send only that amount of money? What is John doing in America? What type of job does he have? So things that the regular mind would see or not see. The student who is on the autism spectrum, who is high functioning, is going to see differently. And those who aren't even not high functioning, once they understand the question, they're going to want to see the logics in it. So differentiated instruction is another means that we use in our schools to help our students to navigate the education system. I must say, I just realized I didn't share this. In our high schools, I did say we have the alternative pathway to secondary education. We call it the APS approach. And what we have are, across the island, we have selected schools that have students on pathway 1, 2, and 3. Just as I told you, in our primary schools, we have the proficiency pathway, red, amber, green. In our high school, we have pathways 1, 2, and 3. Pathway 1 are those students who are functioning well and can manage and independent learners. They move on to CXE. Then we have those students who are on pathway 2 who need a little assistance to help them get to pathway 1 to move to the CSET. Then we have the pathway 3. Most of these students are the ones who did not do well in the PEP examinations, mostly because they cannot read and also because they have a special need that went unidentified. So many of our children in our secondary school have autism spectrum. They are on the autism spectrum. They get into our secondary school undiagnosed, and it's through the processes in the school that they are identified. We have the APS coach, who is the person in charge of the APS approach in the school. This person is a special educator who is trained to identify, treat these types of situations. And so the student is given remediation through pull-out sessions. So they are pulled in groups of 5 or smaller 3 and are treated based on their interest, their learning needs, and where they are operating presently. Sometimes they have one-on-one instruction depending on the need. And we see many of our children from pathway 3 move into pathway 2 and from pathway 2 to pathway 1. We even have some isolated cases where children move from pathway 3 right into pathway 1. And then some of these children are supported in the classroom as well, where the APS coach will go in and sit and do observation and also work with the teacher doing parallel teaching and so on. And so that's a part of our differentiated instruction in our secondary schools. So what are the provisions through the Ministry of Education and Youth? So we have diagnosis, identification from the school level, and then a referral is done for the student to go get in assessment, psychoeducational assessment done. There's an early stimulation program in Montego Bay. This program is located at the Montego Bay Learning Center in the Catherine Hall area. And this program runs 0 to 6, and it's a program that treats with students who have developmental disabilities. We have the student support teams in each region. So we have 7 educational regions across the island, regions 1 to 7. Montego Bay is region 4, Kingston is region 1, St. Anne is region 3. I could give you them in order, but if you go online, you'll find them. And in each region, we have a special needs coordinator who coordinates the process for special education. And then there's a student support team, the SS team, made up of the clinical psychologists and educational psychologists and a diagnostician. However, in the parishes, in region 5, which is Manchester and St. Elizabeth, and region 4, Hanover, Westmoreland, and St. James, we do not have that team because we have the diagnostic centers. So we have the Sam Sharp Diagnostic Center in Montego Bay, St. James, and we have the Church Teachers College Diagnostic Center in Manchester. So they do not have SS teams. Then for treatment, we have shadows. So in many of our schools, we have shadows working with students who need this kind of support. You may walk into any regional office and make the request once you have the assessment report. And the wait time, well, whenever you do it throughout the year, you're not going to get through for that year until the following year because the budgeting has to happen. So I urge you to have it done before May 31 of each year for the upcoming school year. You will get a feedback of approval by July of that year to put things in motion for September. Then there are special accommodations. So some students, the children we have on the autism spectrum, they need because they sometimes have ADHD, they don't pay attention very well. They need somebody to keep them on task. So we have prompters who go with them. Some of them do not write very well. They have dysgraphia or so on. We get somebody to go write with them. So depending on the need and the recommendations of the assessment report, they will get accommodations accordingly. We have special education units in different schools. We have segregated schools, like I explained before. We have intervention plans, placement, and financial assistance. Now, the financial assistance are granted to students who are in schools that offer special education services and have a memorandum of understanding with the Ministry of Education. And this too, the application must be done by May 31 of each year. And for further information, you may contact Ms. Dion Gale. She's the Assistant Chief Education Officer in the Special Education Unit. The number is there. And so is the email address for the unit and the early stimulation program. I'll leave that for a while so that you can take it down if you need it. I'm hoping that it's taken down by now. Somebody need to screenshot it or something. Just make sure you have it down. Are there any questions? That's the end of my presentation.
Thank you so much, Mrs. Sinclair. There are some questions indeed.
All right. Not a problem.
So one person is asking, do the private school teachers benefit from the special education sessions as well? Are there any processes to ensure these teachers are equipped? And what systems are in place to facilitate auditing of said process?
All right. So first question was if private institution teachers benefit from or teaching summer programs. Sure. So all the teachers who are interested in attending just go through the registration process that are sent to these schools. So all the private schools that we have a memorandum of understanding with would have gotten the communication as to dates and so on, links and so on, and the number of teachers to attend because there is a registration process. Your second question, Dr. Morris, was, sorry about that.
The second part of the question is, are there any processes to ensure that these teachers are equipped, and what systems are in place to facilitate auditing of that process if it exists?
All right, so the Ministry of Education cannot mandate private institutions to do certain training, but buried in the memorandum of understanding that we would have with these institutions, they are mandated to do training. And of course, we are apprised when trainings are going on. The Montego Bay Autism Center, for instance, has training every single week, and the proprietor participates in our session, sometimes even offering trainings as well. The auditing process, the Ministry of Education, we have the special education unit that goes in to these schools to audit how teaching and learning takes place. And also from the Ministry of Education, we have the independent schools unit, and they go in to audit how the documentations are being done, how the intakes are being done, pupil-teacher ratio, and those type of things. So there are systems in place to safeguard our students, and we are still, as we speak, working on other systems to promote better teaching and learning and to provide parents with the type of support they need to get the children where they should be through success.
I think the answer to this is, can the ministry put training in teachers' college? I think special education. Special education, I think.
I wanted to speak to that. So across the island, we only have 2 institutions that do special education training, the Sam Sharp Teachers College and the Michael University College. And that is the challenge that we're facing. Another challenge that we're facing is the attrition rate of special educators based on the intake from other countries as the United States and the United Kingdom. So our turnover rate is really too slow in order for us to have the gamut of teachers that we would need who are special education trained. And to add to that, all our programs that are in our teachers training institutions, they do have courses that teachers must take that speak to teaching and learning special needs students. But the problem is that these are just not enough to bolster the success of our teachers in catering to the students when they get into the classroom. And that is the truth. So we're working on building stronger relationships in order for us to be able to inform how we train our teachers. And when we go out to do assessment, many of our education officers and so on are persons who go into our schools to monitor how teaching practice is being done by those teachers who are in college and currently serving as teachers training in our private and public and high schools. And when we get to do that, we get to provide the feedback as to what needs to be done in the college. And when we meet sometimes nationally, we have those types of conversations.
All right. There is another question here. Can persons volunteer to work with a child with autism if they apply for a shadow and they aren't going to get it for the new school year because they apply within the same year?
Okay. So that is going to be a discussion between the institution and the person, because we have to safeguard. When we look at the legal ramifications of just having anybody in a school to serve a student, that is where the challenge is. So it will have to be a discussion between the school and the person to serve regarding screening and the rights of the child and protection in the school. Because remember now, the student who is going to be served is not the only student in the school. And we have to ensure that the person who is serving, volunteer though it may be, is safe to be around children. Think about SISOCA, Office of Children's Registry, and so on. We have to ensure these. So yes, it is possible. And it is best to have conversations with the Ministry of Education and the institution you intend to serve in.
Thank you so much, Mrs. Sinclair.
You're welcome. And thank you so much for this forum.
There is one other question here.
Sure.
Is there a list of inclusive schools for ASD children at the primary level? And I think you mentioned some of them.
All right.
But as part of
inclusive, let me make sure I'm getting what the person's asked. Inclusive meaning a school that treats with mainstream children as well as students with autism spectrum disorder. All our schools are inclusive in that regard. However, we just started the inclusive school leadership for principals training across the island about 2 years ago. And so 3 years ago, 2021, 3 years ago. And so our teachers are going, and principals are going through training processes to ensure that they understand what inclusion should look like. Because the truth is, many schools do not want to take children with autism. They don't want to take children with any special need at all because of the high standards placed on schools for turning over high yields in terms of achievement, PEP results, and so on. So many principals are afraid. And also because they do not have enough trained persons. They don't have the human resource to treat with the autism spectrum disorder. They are afraid. And because of that, we have to be doing intentional and intensive training with our principals to get them to understand that it is not going to be something against them, because we do have all these children in our schools, even if they're undiagnosed. So by getting the training, they're equipping themselves to treat with the situations that are within their schools. So all our schools are inclusive. The ones that I listed on the right, the Edge Hill, the Woodlawn, the Landilo, were the schools that are segregated, that speak specifically to special education. All our primary schools are inclusive.
All right. Other thing, lots of school leaders, principals are afraid to have children with special needs within their institutions. And they oftentimes speak about assessments from the Ministry of Education. So they'll say the Ministry of Education is coming and I can't let them see this child at school. So it seems as if there is a burden placed, or perceived burden, as it pertains to the Ministry of Education and having these children in school. Could you just clarify that for us, or
that is a misconception and some misunderstanding. The ministry does not go into school and try to sift those ones who have special needs and do whatever else to those ones who do not have special needs. So it is a misunderstanding. What I will say though is that any school, based on the code of regulation, a child is entitled to have access to any school that is within the closest proximity to the child. If we are facing challenges, it is best to reach out to the Ministry of Education to get assistance for placement. Some principals are apprehensive because they are not sure of how to treat with a child who has a special need. It's not about the ministry going in and casting some student out or saying we can't see this child. Every child has the right to public education and in the school that is closest to his or her home.
We thank you so much again, Mrs. Sinclair.
You,
This
Doctor.
was really an excellent, informative presentation, and we truly appreciate this partnership. And going forward, we certainly will be calling on you again to assist us in our efforts. Thanks again, Mrs. Sinclair. So we are running right ahead with our program, and next up, we will hear from Early Stimulation Program. Mrs. Gunter Gale will be coming to us from the Early Stimulation Program. Mrs. Gunter Gale.
There's
So
no Mrs.
Mrs.
Gunter Gale online.
No, not online. All right. So the next.
So I believe our next person then is Dr. Norelli Ramsey. Dr. Ramsey, thank you for being with us. Over to you. You're muted.
Hello, good afternoon.
Hi, afternoon. We can
Can
hear you
everybody
and see you. Yeah.
hear me?
Yes.
Wonderful. Let me see if I can get my presentation up.
Perfect.
Can you all see my presentation?
A parent's perspective.
Wonderful. Okay, so I'm here to talk to you today about the Jamaica Autism Support Association, a parent's perspective. My name is, as on the screen, Dr. Norelli Morrison Ramsey, and I am a doctor of physical therapy. Before I begin, I just want to say thanks to the PAJ Outreach Program for having the Jamaica Autism Support Association represented here. And without further ado, let me start. I would like to start, first of all, by giving you guys a little backstory about my autism parent journey. My son, Alexander, who I raised with my husband, was conceived during my doctoral program, which made my doctoral program very interesting. I had an uneventful pregnancy, I had to be induced, and when he was born, he did not cry. His APGAR score, for those who are pediatricians on the Zoom meeting, was 4, and then it went all the way up to 9. He had Erb's palsy, which means that one side of his body, it was the left side, was not moving, but that spontaneously resolved. And otherwise, he had normal development. He was walking, he started saying single words. And then at 18 months, after his 18-month vaccination, and I know that Dr. Garbut has said that there is no association with vaccines and autism. However, for us, it was a very unhappy coincidence that after his vaccination, he started to regress and not speak. So Alexander's diagnosis was autism spectrum disorder. He was diagnosed in 2014. We went to his pediatrician, told her that he started speaking and then he stopped speaking. And she said, boy, boys, they tend to not speak early, so just watch him. But he had already started talking. And so we were very concerned that he had just stopped talking. I, being the physical therapist that I am, I need a functional child in my mind. And so I knew a speech therapist at the time and carried Alexander to the speech therapist. She was the one who suggested that he get an assessment, and the wonderful Dr. Garbut assessed Alexander and told us that he had autism spectrum disorder. It was shocking for us, but we took it in stride. She gave us all of the information that we needed to get him started on the other interventions like OT, occupational therapy, speech therapy, ABA, and so that's how we started. However, in when he was 5, so that's 2016, he had his first obvious seizure, and he was not diagnosed with epilepsy until 2011 because the 2016 episode was a singular episode that we could see. He had focal seizures, so it is quite possible that we missed others, but that was the one that was major for us. In 2021, they started to ramp up nicely, and he was then diagnosed with epilepsy. And we were having trouble finding the right medication for him. He went and ended up doing a blood test, and we found out that he had mild beta thalassemia. I say all of this to say that in our journey with Alexander, we have come in contact with many practitioners. And as I said, it has been a journey. So I'm going to start by talking to you about how we have navigated this journey. Parenting autism. First of all, I'd like to say that when he was diagnosed, we realized very early that we would have to be our child's voice. Alexander didn't start speaking again until closer to age 6. His first words were "Happy birthday, Grandma." And so from then, though, he has not been able to communicate conversantly. So he can say, he can ask for what he needs, but he is not at the point where he will have active conversations with you in a fluent way. And so I have had to navigate in all of this, talking to all of these practitioners about what is going on with him, what his presentations are. And in doing so, I have had to know my child. Now, I know that for all parents, this diagnosis can be overwhelming, and we can tend to focus on what the diagnosis is, what all of the interventions are that are required at the time. and in my case, all of the doctors and therapists and so on that we have to interact with. However, in doing all of that, we have a tendency, I know I did, to not acknowledge who my child was as a person. And so because I recognize that I have to be his voice, I now recognize, especially as he gets older, I have to know who he is as a person. And we recognize that he loved music and he liked the alphabet and he had a desire to get as much knowledge as possible. So we gave him all the books. We gave him every book known to man. He liked reading dictionaries and encyclopedias, and so we gave them to him. And in doing so, we saw where his language developed because he was using all of this information and all of the videos, etc. And I know videos are controversial, but he actually uses the videos to communicate with us. He takes the language from the videos that he watches and he translates that into giving us information since we've been listening to him, so he can communicate with us. So also, having now known my child, I have become his primary advocate. We have had to, primary advocate for him means also being able to go into the school system and talk to his teachers and the principal and all of his therapists and coming to a consensus as to how it is that we are going to give Alexander all the tools he needs to navigate life. As a physical therapist, one of the things that we usually say is we need to position our patients for success. And that is what we have tried to do with our son. As a physical therapist, it's position, meaning physical position. But for my child, I have had to find ways in which we could get the best out of him and using all of the persons that we have around us, the therapists, the doctors, etc., so that I could get him to a place where he's functional in this world. And we're still working on it. And because I've had to do that, I've had to collaborate with everyone, but also I've had to translate those collaborations into teaching him and following through with all the therapies and the interventions and the medications that he has had to do. I have had to do that follow through for him. And that teaching and that collaboration tends to be very exhausting. Very exhausting, very tiring. It can be overwhelming and isolating. And anyone who has who acknowledges that they have a child on the spectrum, they also have. I've spoken to a lot of parents at this point who have children on the spectrum, and they express some form at some point, one of the 7 stages of grief. When we started, the first stage is shock and denial. I was in shock. I was not in denial. I believe Dr. Garbut, when she said he had autism, I just didn't know what that was. And so I went and did a lot of reading. I also had pain, sadness, and guilt. I wondered what was wrong with me, why my son had to turn out with autism. What was the reason, if it was something I did in pregnancy? And then we went through to the stage of anger and bargaining. Now, mothers tend not to do so much anger and bargaining, although I do know a few, but more dads. I know my husband struggled even now with being very angry at the fact that his son has to go through all of the challenges that come with having a child on the autism spectrum. And you go through depression as well. If there's lots of sadness, and with this sadness, for me, there was isolation. I didn't want to carry my child anywhere. I didn't want to have to deal with people saying my child was bad or any of those things. And so, you know, when you are isolated and sad, you tend to get depressed. But also there is, you know, getting all the information you need, reconstructing and working through this diagnosis and doing the best that you can with the information that you have, and having acceptance and hope. But in all of this, I recognized that we needed some support. Everyone who knows me knows that I am an only child in a house with only children. Both my husband and myself and my son are all only children. And so because of this, we don't have a lot of family support. I, because of the isolation, did not want to join or have any kind of support. I was more than happy to be in my little bubble with my child. However, other autism parents encouraged me to join the Jamaica Autism Support Association, and it has been life-changing ever since. The Jamaica Autism Support Association was started in 2006. It was started by Kathy Chang, one of the co-founders, and its goal is to help parents to navigate these choppy autism waters. One of the first things that they do is they provide emotional support. So it is a support group that is for parents and by parents. Our meetings don't include children because in our meetings we talk about things that we may not want our children to hear. Being a parent of a child on the spectrum can be very difficult. There are some feelings that we may have that we may not want to say, and we may not want to confess to regular people that we have. But we have a safe space to discuss those things with other parents who are going through the same sorts of challenges and triumphs. And we can look ahead. There are several parents of several age groups throughout the association. And so we can see how, or have an idea of how our children will turn out, what is possible for them. We also advocate to the wider society. So here I am talking to you about JASA, and we do a lot of advocating. We talk to government entities and educational institutions. They come to us and we discuss how we can make the lives of children on the spectrum better. And then we provide information in a practical way. So at our meetings, we will have professionals who come to discuss their varying specialties to help those parents who, well, all of us, but especially those parents who may not be able to afford some of the interventions that are necessary. We try to have persons like occupational therapists, speech therapists, persons from JCPD. We've had early stimulation projects. Everyone who has been on this Zoom meeting has also been to JASA to have conversations with us about how we can navigate this and practical ways to deal with our children. And you can join and help. For the pediatricians that may be on this call, we are always looking for specialists to come and present to us, to come and help us to go through the process. Dr. Garbut had spoken about the fact that autism comes with various comorbidities, and we would love specialists who can come and talk to us about those things, also general practitioners who can help us to see things that we might miss in our children. And also, parents on this call can also join the Jamaica Autism Support Association by emailing us at jasa.jm2k9@gmail.com. It's on the screen. You can also follow us on our social media pages. Facebook is jasa.jamaica and Instagram is jasa_Jamaica. It is imperative for us as parents to get support and to get help, because this can be a lonely road. But there is support out there. There is help for us to be able to do this in a way that is fulsome, to do it in a way where you're in community, and to help each other so that we can understand better how to help our children. So to recap, we are the voice of our children. We have to know them. We have to advocate for them and to teach them. And that can come with isolation, sadness, grief. But the Jamaica Autism Support Association has been a great help to me and a great support to me. And it can also be a great support to you. You can email us today and start supporting. We can start supporting each other through our autism journey. I love somebody with autism. I know all of you do too. Thank you for listening to me.
Thank you so much, Dr. Ramsey. That was like you ran a marathon in 10 minutes. we truly appreciate that, and we really can see how this journey has really moved you from one place to another, full circles, and how much you love your son. And I think that the parents on this webinar can really appreciate everything that you have said in your presentation. And we thank you for delivering such a riveting and heartwarming presentation, presenting us with some sobering realities, and that parents are to be the advocate and the voice for their children and know their children and be able to know what is in the best interest of their children. And thank you so much again, Dr. Ramsey. I know that there are a lot of questions for you, so let me just go question and answer. And what advice or support would you give to a single parent who is unemployed and has a child who is diagnosed with autism?
Okay, so the first thing I would say is the first thing I said in my presentation, which is that you need to be the voice of your child, but you also need to get to know your child. Autism gets easier when you are equipped with all of the information that you can about autism itself, but also about your child. Every child, I know we've heard this throughout all of the presentations. Once you've met a child on the spectrum, you've met only that child on the spectrum. Your child is special and unique, and you can reach your child if you know them. I know it is difficult. I know that we go through different stages. The younger they are, is the more difficult it is. But you also have to recognize and understand that you are the person who is going to teach your child everything. Autism children who are on the spectrum don't necessarily learn like the other children, and you have to teach them. Well, I had to teach my son everything, every step of every single thing. And so take the time, if you're unemployed and you are home with your child, to spend the time with your child. Get to love your child. You can feel resentment, but get to know your child. That is the first thing I would say. And also, as much help as you possibly can get it. Use up your family members, use up your friends. Everybody needs to know that your child is special and they need to come on board with you. That's my advice.
Thank you so much, Dr. Ramsey. And everyone in the chat is saying, great presentation, and they truly appreciate your presentation. And that's an echo from all of us. Thank you. All right, so we will now run into our next presentation from early stimulation. Mrs. Gunter Gale will now present to us on the early stimulation program, what the program entails, and how you can access that program. Over to you, Mrs. Gale.
Good afternoon, everyone. Good afternoon, Dr. Morris, and all those persons on the platform. I will be sharing this afternoon on the early stimulation program and how best the program can assist with our children with varying types of disabilities, including those of our children with autism. So the early stimulation program, can you see this slide?
Yes, we can. Yeah, Ministry of Labor and Social Security Early Stimulation Program.
Right. So the Early Stimulation Program is a program of the Ministry of Labor and Social Security that works in collaboration with the Ministry of Education, the Ministry of Health, and various agencies to provide early intervention services for young children with various types of developmental disabilities, young children from birth to 6 years old. Now, among the disabilities managed by the early stimulation program are those children with learning disabilities, children with autism, children with intellectual impairment, children with cerebral palsy, children who are physically challenged, those with attention deficit hyperactive disorder, ADHD, visual impairment, hearing impairment, cultural familiar retardation, multiple disabilities. Children are referred to the program by the healthcare workers, early childhood practitioners, social workers, and by other parents who have benefited from the services. What is really done at the early stimulation program? An in-depth developmental screening. And so a child is referred to the early stim, and the child might be, say, 4 years biologically. But after the assessment, developmental screening assessment, the child may come out at 2 years or 6 months old. So we see where the child is at in his or her development. A review process is also done. Therapeutic services, physical therapy, counseling, parent orientation and parenting workshops, special education. How do we carry out the various services? And so we do what is called home visits. The child sometimes is visited at the nursery or at the school. Training for parents and caregivers in stimulation techniques. Community-based rehabilitation that is carried out by the trained child development officer. And so we give you at a glance the early stimulation program. Here we have assessment and diagnosis. We form a working diagnosis of what might be wrong with this child, what might be happening. We do what we call the intervention, as I mentioned earlier on. For every child that is referred to the early STIM, a tailored early intervention program is set up for that child. And so sometimes you have 4 different children with the same situation or diagnosis, but the program might be different depending on the child, where the child is at in his or her development. We have physiotherapy, where the child receives, if necessary or if needed, physiotherapy treatment sessions, parent counseling, parent training and support groups. You know, it is hard, very hard, when a mother has been told that your child has this or that condition, your child will never ever be able to do so and so. And so we see so many parents, not just mothers, but fathers, really in distraught, broken, disappointed, you know, to know that my child I look forward for a normal, healthy child, as all parents do. Look forward for a normal, healthy child. And to learn that your child might have some kind of developmental delays or something might be wrong can really, really throws you off. You know, life happens. And so we seek to provide the kind of support for this parent training, parent support, public education, various social activities. Our sports day will be next week, Thursday, over in Kingston. And all our students with special need, all our children will take active part in the various activities. Fun days, social activities, referrals. You know, at first we may do the screening and assessment, and we realize that the child, or we find out that the child might have delay in one area, and after the review, we may find something else. We may realize that we need to refer this child to the nutrition clinic. We may realize that we need to refer this child to the JAD or somewhere else. And so the referral system, re-evaluation and reviews. So every 6 months, a re-evaluation is done with this child to see what do we need to change, what do we need to do differently, to see whether or not progress, you know, is being made, and so on. So a re-evaluation is done with each child. Behavior therapy. We also carry out behavior modification and behavior therapy through our various child development officers. Community-based rehabilitation, where the intervention is taken into the homes, sometimes at the basic school, if the child is in the school, where a pull-out session is being done to work with this child. If the child is at the nursery, then we do the same. The parishes presently served: Kingston and St. Andrew, St. Catherine, St. Thomas, St. Mary, Portland, St. James, St. Elizabeth, and St. Anne. Our latest initiative to the program is the Mobile Intervention Unit, which provides therapeutic services and educational services for children with special needs birth to 6 in rural communities. We know that Kingston is not Jamaica, and so we have been trying to take the services in to some of our rural communities. We have not covered all. We have a good way to go, but we are trying to take the services in. And so we set up dates, make arrangements for persons to meet us at various locations on a monthly basis in some of these rural communities, where we actually carry out the intervention with our retrofitted unit and a tent in the parishes. Some of the communities, some of the numbers we are presently serving over 3,000 children with developmental disabilities. Oh, that is a picture of the mobile intervention unit that goes into some of these communities. We also have 2 child development centers. We have started out in Kingston in the Beaumont Gardens community, where we are presently serving 196 children in a teaching learning environment where they attend school on a daily basis and are benefiting from the special early childhood education. If you see children around the table with various types of disability, you may see one little boy there with Down syndrome. We have one little boy here with hydrocephalus and various. It's a mix around the table, learning disabilities, autism. And so we work with our children to assist them to reach their highest potential and then transition to the primary level, whether it be special education or the regular school system. We have quite a number of children leaving the early stimulation program who have transitioned into the regular school system at the end of the intervention. Some may go into special education programs. We are experiencing that they be as practical and realistic as possible. You know, at the end of the program, if a child needs special intervention, then the child should continue to receive special intervention. We say to the parents, if a cow can only produce a quart of milk, you don't try to squeeze a gallon, because what will happen? Blood, pus, fester, and so you be as practical and realistic as possible in catering to the needs of our children with various types of disabilities. Some of the classroom setting may have specialized equipment. Some may have special standards for children with cerebral palsy or specialized chairs, supportive chairs, wedges and prone, and so forth. And we are working together for our children to achieve the full potential. We believe in our children with special needs, whatever types of disabling condition, be it autism, Down syndrome, cognitive impairment, cerebral palsy, whatever, we try to reach the children and to bring out the best in our children through continued intervention and therapy. And at the end of the 6 years, being with the early stimulation, we do what we call a transition exercise or a graduation. And if you see in the picture there, our children, at least 50 children each year, move on to primary level education. Whether you use a wheelchair or walker or not, we encourage the children to graduate in fine style, just as their peers. So each year, if you look in the picture, you will see our beautiful children there in their graduation exercise. Last year, one of our graduates with cerebral palsy did so very well. He brought everyone in the audience to tears when he did his valedictorian speech. And so we know our children, if given the right opportunity, they can be the best that they can be. And so we encourage stimulation. We encourage early intervention. All children need stimulation, especially those children with developmental disabilities. So we encourage that. We encourage parents not to wait until it's too late. The sooner the better. As soon as you suspect that something might be wrong, something is a little off, don't sit and wait and guess and spell. but try to, seek help. Go to your pediatrician, go to your health centers, speak to the child's early childhood teacher, so we can start the program of intervention as early as possible. That is crucial to the child's growth and development. And so we provide a kind of support at the early stimulation program in assisting our children to attain their full potential. And thank you so much. Together we can shine. Thank you so much.
Thanks again, Mrs. Gunter Gale, for being on this program. You know, we can always depend on you to be there for the children. And thanks for the great work that you've been doing at the early stimulation program. And I see the parishes keep expanding. And I know that the next one on it will be Westmoreland, right?
Very well, very well.
All right.
Is so true.
All right. So here's a question. My son was referred and the appointment he got is December 2025. Is there any way the waiting period can be less?
Yes. So what we have done, we have sought and we are seeking additional clinical hours. You see, so you might be called in another month or two to begin, because that's what we have been doing, pushing up the dates, earlier dates. So you might be called. I know it's a long wait, especially since COVID, it has really thrown us back. And then we saw a lot of children coming in. A lot of children in numbers have drastically increased since COVID. And so we are trying our best. So even though you're 2025, listen out. You may be called, because that's what we have been doing.
Thank you so much. And one other question, I know you said it before, but just to reiterate, what age do you go up to?
It's really from birth to 6 years. Yes, we do have a few 7 if you learn of that and the program, but it's birth to 6. If the child really came on late and we see that we can really, assist this child in attaining more developmental milestones, and so we try our best, but it's really from birth to 6.
Thank you so much again, Mrs. Gale, and we look forward to the continued partnership. Thank you.
You're most welcome. Thanks for having me.
You're welcome. So now we are over to our final presentation for the day. So our anchor is online waiting to grab the baton and finish today's race. Dr. Brown Earl is our psychologist, and I'm sure that all the presenters told you that having a child diagnosed with autism can be such a psychological event. And so we have here Dr. Brown Earl, who is a stellar psychologist and very much qualified to present to us on the coping with the diagnosis of autism. Over to you, Dr. Brown Earl.
Thank you so very much, Dr. Morris. And I've had a wonderful learning experience, and I'm just going to pull it all together in 5 minutes. It is so very important for us to have this kind of forum. It's critical and key for our families to understand and our friends to understand that this is what's going to be important for our people to learn and to understand. So, as I have the wonderful opportunity of assessing children from all over the island, because as you can just imagine, when Kingston is filled up and Montego Bay does not have enough professionals, they end up coming to Maypen and Mandeville. And so I also have the honor of guiding parents, especially the parents who are having a child for the first time, in coping and how they will care for the child who presents on the spectrum. And so one of the things that we really need to make sure that we do, those of us who are the practitioners, the psychologists, is that we encourage our parents to educate themselves. And so, for example, this forum. So we want to make sure that as we are through with this now, we go on YouTube and we forward it to as many people as possible. If you're old like me, you're going to put it on Facebook. If not, you put it on any of the social media platforms that will allow you to do that. We want our parents and family members and the caregivers, because you'll be so surprised, my friends, how many of our children do not live with their biological parents. Okay, so we want them also to learn about autism spectrum disorder. We want them to understand and learn, as has been shared earlier, of the effect on the child's behavior, the effect on the communication, and of course, very importantly, social interaction, which is where many of our parents and family members have that confusion. But this child is so smart to do this, and then they will do this, but then they don't want to play with anybody, you know? So the more we educate them to understand what we have all learned today, the more powerful the guidance will be and the support will be for our children. We want to encourage our parents also to build a support network, and we have them presenting here today. And so access to these networks, we are encouraging our parents, take up your phone, make a call, get the information, connect with other parents and support groups, and of course, seek professional guidance. Dr. Ramsey has shared that. For my wonderful parents, family members, and caregivers, I want you to encourage in your family lives a daily routine. So this is what we're going to do in the morning. This is what we're going to do during the day. This is what we're going to do at lunchtime. This is what you're going to do in the evenings. Daily routines are very important for children who are identified as autistic, because it provides a sense of security and predictability. Now you can just imagine you in your regular everyday life, how wonderful that is for you. So you can just imagine now how important that sense of security and predictability is for children who are on the spectrum. I want to say this, and don't think I'm pushing or pressing or forcing, but I use the word always there critically. Always use positive reinforcement. Okay, so once a child has done the appropriate behavior, encourage with rewards or praise. Now, please remember, you cannot give the child something expensive and think they might not understand. No, they're going to want something nicer and probably more expensive. Okay, especially if they're at the level 1. So we want to use the positive reinforcement. All of the children who I have assessed who present on the spectrum thus far, they all know the high five. And the high five works so well. But I want them to move on to another activity that I'm trying to use to make a decision regarding their evaluation, the assessment. If I do high five, I can assure you, the typical Caribbean child gives me that high five. So high fives work. I want to use that. We want to use hugs where it is appropriate to do so. Remember, not all the children on the spectrum will want to be hugged. But parents, always, 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 and you heard from Dr. Ramsey earlier, do your best to manage your stressors. Take breaks. I know sometimes you don't want to leave the wonderful child or children because they're crying and making noise, but you need to breathe. So yes, they're crying when you leave them with someone. Just make sure you leave them with someone who you're comfortable with. And just go away for half an hour or an hour. I don't know, if a manicure, pedicure, sit in a river, get some water and soak your feet, whatever it is. Go and have an ice cream. But take your breaks, because remember, if you are highly stressed, you're going to place that stress possibly on the child. Practice your self-care. All right. What are the things that you like to do for yourself? Treat yourself to little things. Prioritize yourself, your partner, and your family's well-being. Please remember, those of you who are in a relationship, your spouse, your partner needs you too. Okay? So you have to make sure that that is also focused on. And of course, what happens to the other children? What happens if your parents live with you? You have the extended family there. You have to work that program so well that everybody feels important. But guess what you can do? Have everybody helping in specific ways. Not a thing is wrong. Or should I say, it's very important to have a family meeting and say, this is where we are. This is the issue that's presenting itself. This is how we all can work together to maximize the potential of this child or these children who have been identified as on the spectrum. Then, of course, let's try to figure out what are the autism-friendly activities. And we heard about some of them earlier. So think about the games. What does your child enjoy? Okay? What I find is that balls are powerful things. So different games with balls will work for some of the children. Art, I see that a lot working very well. So the football can be another thing. Music, we encourage parents, we encourage you to have your children involved in music programs. We see where the children who are on the spectrum and music seem to go hand in hand. Swimming is also another game or activity that we find that the children who present on the spectrum are really actively involved in and doing pretty well in. Celebrations, just like we celebrate for everybody else, please remember, acknowledge every celebration, no matter how small. So we're not saying that you must have an elaborate birthday party, okay? But just a little celebration to say, this is what we are acknowledging, this is what's happening. If your child has done well in a particular activity, there's a celebration. And remember, your celebrations can be small, positive activities. Importantly, communicate effectively. And one of the best ways to communicate effectively is to do what? Is to simplify language, okay? So you don't necessarily want to give a multi-step direction. You tell the child to do 10 different things one time, or even 4 or 5 different things. You can simply say, please pick up the ball. And also remember that even for the child who is not currently now speaking, that child is going to repeat what they hear. So it's going to be very important for you to speak correctly, appropriately, and nicely, because that is what will be replicated. So simple directions, simple identifying of items, and please use correct words so that when the child starts to identify whether it's a body part or items in the home, they use the correct words to identify items. Your self-care again. Remember, respite care is going to be very important. Arrange temporary breaks for yourself. And very importantly, get regular exercise. Parents, caregivers, friends. Walking is a form of exercise. You don't have to go to the gym. So you take that break and you get your bottle of water and you go for a 30-minute walk. That is going to be very, very important. Eating healthy is going to be important for the child, yes, but for you too, because you need a physical strength to cope. All right? Our children are active children. They want to get things done. They want to explore. So you need to make sure that you are physically healthy as well. And get sufficient sleep. So you guide the child for a particular bedtime, okay, and work as best as possible. In my training, what we have seen and what the parents have guided me, what works for them, stimulation off at 8 o'clock. So as much as you want to get some other things done, you just have to train. I remember we talked about the routine earlier. So all lights are off at that time. No, children will vary, right? Children are different. But as best as you can get that routine in, you also will get sufficient rest. Always, as I close, seek professional help. We are here for you. Consult with your pediatricians, your therapists, your counselors, your psychologists, your speech therapists, your occupational therapists, your physiotherapists. Consult with all of us. We are here for you as best as we can. We wish that there were more of us so that we could reach out. But guess what? Those of us who are here, we are only too willing to work with you. So ask for our help, and we will do our best to help you to maximize your child's potential. Thank you very much and have an absolutely wonderful evening.
Thank you so much, Dr. Brown Earl. I see that you have run home and given us the gold medal of this seminar, and we want to really thank you. And Dr. Brown Earl can be found in Mandeville, Manchester, and Clarendon, and she goes to the Gilead Pediatric Center in Maypen, and you can have assessments there as well. We will be putting together that resource list, and we'll be emailing it out to all the persons who have registered for this webinar. The association is working on that. Thank you so much again, Dr. Brown Earl. And I know that there are lots of questions for you. All right, I think that you were so good, Dr. Earl, that everything is all clear. And
yes, sir, it was all said before me. I just summarized it all.
all right, Artie, thank you so much. We would like to thank all the presenters for making today possible. It was a long day, but all the presenters were so engaging, so captivating, and have kept the audience until this time. And we just want to thank you. Certainly, this webinar was intended for the parents and teachers, and I'm sure that they appreciate it. Online, we had up to 500 persons. And Sam, how many persons we had over on YouTube?
At the maximum point was 135.
Right, so we had quite a lot of persons. And for the persons who would like to see it again, or for those who missed it, it will be available over on YouTube. Sam, if you could just post that again in the chat so that persons can copy it and send it out to their friends and colleagues so that they can re-engage with the presentation. Thanks again, everyone, for attending. Any final comments or remarks from the panelists?
Just a reminder for everybody that's looking about the 5K run walk and for autism support, Sunday, June 23, 2024. Information is up on your screen now. It's also been shared in the chat, the flyer and the PDF and the link to register. Thank you.
All right. Thanks again, everyone. And have a good Sunday afternoon. Bye-bye.
Bye-bye. Thanks, everyone. Have a safe evening. Cheers.